Perfect. So, hi everyone. My name is Kayla. I am the Senior Director at Elephants&Tea, and I am so excited to welcome everybody here to Season 2 of AYA Power. If you joined us last season, welcome back. If you are new to Power, we are so excited and honored that you are choosing to spend a little bit of time with us here today. Just a little bit of housekeeping and some background from me. So, the reason that you're here is Power. The mission of Power really is to provide oncology trainees and those that are in the field of oncology care with some high yield education and easily accessible resources to improve care delivery and outcomes for all adolescents and young adults diagnosed with cancer. Our structure of Power is really exciting. We do once a month live sessions that will all be recorded. And the wonderful thing about Power that we find pretty awesome is that on our website, there's also all of our sessions and additional information. So everything from season 1 is also available on our website, which I will drop into the chat so that you all have our website that you can visit and check out season 1. Additionally, with all of our on-demand content, there are journal articles available that kind of speak to the issues and the topics that our wonderful experts are highlighting, as well as just information about the sessions that are going to be coming up for the rest of the year. So we have 9 amazing sessions for season 2, and we are just so excited to be here and that you are a part of it. So please make sure you check out the website for all of the other kind of content and information that lives there. A little bit of housekeeping for us on our end. First of all, a huge thank you to the AYA Oncology Education Working Group. It was through their efforts that they identified a gap in education surrounding AYA-specific issues. So came to Elephants&Tea and the rest of the team to really put together Power to start addressing those gaps and kind of all of the needs that need to be fulfilled. We also want to send a huge thank you to our sponsors, AZI and the I'm Not Done Yet Foundation, for supporting the program and the mission of Power. This is a webinar, so you can see that chat is up and running, and please use the Q&A for questions that you would like to ask of our amazing speaker, because that is really kind of the meat of the rest of the conversation that we have. Mike will do a wonderful kind of presentation for everyone, but we really love the conversations and the discussions that we get to have as well. So it's really an opportunity to connect with our experts and learn from them. So with that, I am so honored and excited to introduce our very first speaker for Power. This is Dr. Mike Roth. He is a professor of pediatrics at MD Anderson Cancer Center and also the co-director of the Adolescent and Young Adult Program and director of the Childhood Cancer Survivorship Program. I will not say any more about him. I could go on, but I will kick it over to Mike to get us started.
Perfect. Thank you so much, Kayla. Can you confirm you can see the slides and hear me okay?
I can see your desktop. I cannot see the slides.
All right, hold on one second. Hopefully my email didn't say anything bad. How about now?
Perfect. You are good.
Okay, haven't done that in a while. Thanks so much, Kayla, for the opportunity to talk with the group. Thanks to everyone who has returned for season 2. Thanks to those who are new to the program. I must say that every time Kayla mentioned season 2, I was thinking that my family is looking forward to season 2 of the show Wednesday, about Wednesday Addams on Netflix. I hope this is as exciting as that will be. Today we're talking about persistent gaps in AYA cancer care. This is meant to be a short, sort of quick overview of where we need to go in the future and how much more progress we need to make. I do not have any disclosures that are relevant here, and I'm hoping that you guys will put in some good questions in the chat and we could have a good conversation at the end. So this is sort of the overview, and it's a little bit of a hodgepodge of gaps and disparities. And specifically, we'll address gaps in guideline, concordant care, both for cancer treatment as well as supportive care, persistent gaps in trial enrollment for AYAs, fertility preservation challenges, post-treatment survivorship care and prevention of subsequent malignancies. There's a lot of work we still need to do, despite the fact that we've made a lot of progress to date. So let's get kicked off and focus on where our AYAs are receiving their care. So despite the fact that many pediatric oncologists do a fair amount of AYA research, and I am a pediatric oncologist, most AYAs do not get treated in the pediatric cancer care setting. They get treated on the adult side, and most AYAs get treated in the community setting as opposed to the academic cancer care setting. And we know that often treatment and available resources differ by care setting, and that's led to some challenges in terms of outcome disparities, which we'll see on the next few slides. So this is really nice work by Julie Wolfson and others, such as Alicia Alvarez and other investigators have also shown similar findings across disease groups. But if you look at the treatment setting, so if you look at academic sites and academic sites that are pediatric sites versus non-academic sites, specifically for the diagnoses of acute lymphoblastic leukemia, CNS tumors, sarcomas, we clearly see a survival disparity for those patients who are treated at the academic site having better survival than those in the lower resourced community site. The question of why is still persistent, and there's a fair amount of ongoing work and planned work to address these gaps. But we really don't know whether it's the fact that the treatment being delivered differs in terms of are patients receiving guideline concordant or guideline recommended care? Are they receiving the same supportive care that's needed to make sure that patients make it through therapy successfully? So we have a lot of work to do in the community. And this is the challenge that we still face, is that there's a gap in knowledge. Most studies on AYA cancer care and outcomes are conducted in academic settings. So we actually don't know a whole lot about the care that's delivered specifically in the community oncology setting, and that's where we need to go next. If most patients are treated in the community setting, and we know that outcomes for many seem to be a little bit poorer, we now need to dive in and understand how we can narrow the gap, first by understanding what are the challenges, and then next by actually filling that gap, addressing those challenges, and improving care outcomes. What do we know? Well, looking at cancer registry data, and this is data from the Texas Cancer Registry led by Caitlin Murphy, we know that there are persistent gaps in survival outcomes for those who have sociodemographic disparities. So specifically, individuals who have fewer resources or socioeconomic resources, males and females, continue to have poor 5-year overall survival. We also know that individuals who identify as Hispanic or Black, they also have persistent disparities in survival. And even though survival is improving for all, it's not improving as much for those who face the greatest disparities. And at this rate, those individuals will never catch up to those who are higher resourced and those who identify as non-Hispanic white. Our team has done some work looking at early death, so death shortly after diagnosis, and this was published last year by Amy Berkman, and it used a SEER cancer registry. And what we found is that there are definitely disparities based on cancer diagnosis. And interestingly, some of the rarer diagnoses in AYAs, so these are diagnoses seen in older adults, such as some of the GI cancers and lung cancers, those are associated with the highest risk of death within 2 months of diagnosis. And that's likely because these patients are presenting with very late stage disease because they're either being underdiagnosed or misdiagnosed or not diagnosed at all until very late in the game. As expected, patients with AML and AYAs with ALL, so heme malignancies, as well as CNS tumors, often they can present very, very sick. And for them, many of those patients will succumb to their disease or some of the side effects from the treatment early in their disease within 2 months. And if you look at AYAs with AML, it's as many as 10% are dying shortly after their diagnosis. If we look specifically with in the AYA population who has hematologic malignancies, there's disparities within this population, specifically race, ethnicity, as well as sociodemographics seem to be associated with differential outcomes as well. Individuals who are Hispanic and Black have a higher risk of early death, as well as those without insurance and those from who have fewer socioeconomic resources. So as expected, as we see with longer term survival, but equally concerning. And we need to make sure we understand why these patients are having such poor outcomes at the earliest stages of diagnosis. So access to care, does it matter? The answer is yes, and we sort of expected to see this. So with the implementation of the Affordable Care Act, now almost 15 years ago, it was a real opportunity to study a point in time where access to care changed for many patients. The dependent care expansion, highlighted here as the DCE, allowed AYAs up to age 26 to remain on their parents' insurance. And the figure on the left shows that many AYAs gained access to insurance and access to care shortly after 2010, after the law was enacted. Figure on the right, so this is a really nice study that Archie Blyer led, and it was recently published in Cancer. And what it shows is that clearly the time after the enactment of the ACA and the DCE, those individuals who are most likely to be impacted by this law, AYAs age 19 to 25, had the highest increase in their relative survival. So all age groups here did have improvements in their survival, but it really was that 19 to 25-year population who had a change in their access to insurance coverage. And clearly that was associated with improvement in survival. There's still a lot more work to do on this, but this is probably the greatest evidence we've seen so far, along with a few other papers showing Medicaid expansion, or those states that had Medicaid expansion also saw similarly impressive improvements in survival shortly after the enactment and increased insurance access. I've done a lot of work in the past looking at AYA clinical trial enrollment, and we know the way we make improvement in cancer outcomes, survival, quality of life is through cancer clinical trials. We also, for many years, have seen that figure on the top left here, where there's a valley in AYA enrollment. Specifically, males in their 20s rarely enroll on trials. Black males, other minoritized populations rarely enroll on trials. And that really prevents a knowledge gap and prevents us or hinders us from making more progress. If you look at the figure on the top right, you can see it's probably about somewhere from 2 to 5% of AYAs participate on cancer clinical trials. And you might say, well, that's similar to older adults in terms of the percentage. Yes, that may be true, but the denominator is very different. And because there's thankfully only 85,000 AYAs diagnosed with cancer in this country every year, you need to capture a larger proportion of those patients on trials to be able to ask and answer questions about novel agents, novel targets, and how do we improve quality of life. Additionally, we get most of our biospecimens from patients who enroll on cancer clinical trials. And if fewer AYAs enroll, then we do not have the biospecimens to be able to identify new targets and determine which agents should be incorporated in future studies. Fertility preservation. AYAs are young. AYAs have their whole future ahead of them, and they deserve the opportunity to meet life goals, personal goals, career goals, family goals as well. And unfortunately, cancer treatment often takes some of those goals away from patients. And we as providers need to do a better job equipping patients to make decisions prior to the start of treatment, specifically as it pertains to the ability to build a family post-treatment. We clearly know that surgery, radiation therapy, alkylating agents, and some other agents place AYAs at a higher risk for infertility due to cancer treatment. We've got a fair amount of information these days, and we can counsel patients pretty well based on their risk, as long as they're not more sort of novel or newer agents. Unfortunately, despite clear guidelines that all AYAs deserve and should receive counseling on the potential risk for infertility post-treatment, that they should receive this information prior to the start of treatment, most never receive this information. And there are likely disparities of who receives this information based on cancer care setting: pediatric, adult, academic, community setting. Few AYAs are ever counseled, and then fewer ever are given the opportunity to preserve their fertility with banking approaches, male, female fertility banking. And we also know that there's a lot of barriers to both sperm banking as well as oocyte embryo preservation, ovarian tissue cryopreservation, beyond just the counseling component, but also access to care and the cost, which is a large barrier specifically for our female patients. When we think about our patients and why they got cancer and their risk after they have this cancer of developing subsequent cancers, we know that many AYAs likely carry cancer predisposition syndromes. They have alterations in their germline DNA that put them at risk for developing not just one, but many cancers throughout their lifetime. And they deserve different screening based on their risk for future cancers. Unfortunately, similar to fertility counseling, few AYAs actually ever meet with a genetic counselor. Fewer ever get recommended genetic testing. Figure on the right is for young women with a personal history of breast cancer, and specifically looking at those patients with young onset breast cancer. Essentially, all of them are recommended by NCCN guidelines to receive counseling and testing. And this is a prior study in JCO, which showed that less than 20% of patients who have clear evidence that they need a genetic counseling and genetic testing ever get access to any of those. We know that there are barriers to receipt of genetic counseling and testing depending on location of care, provider knowledge, as well as access in the local community or site. We also know that telegenetics can increase access to genetic counseling and testing. And Tara Henderson and Angela Bradbury are leading a very exciting study for AYAs, and they hope to fill this gap in care by providing patients access to telegenetics. Survivorship. Wonderful, wonderful manuscript that just came out from the Office of Cancer Survivorship at the NCI, which identified for the first time that there are over 2 million survivors of AYA cancer living in the US. Typically, when we talk about young people with cancer, we're talking about 5% of all cancers or 80,000 patients a year, a sizable and meaningful population. However, that doesn't highlight the decades of life that are impacted by cancer. Over 2 million survivors. If you multiply that by the number of years of survivorship, you are talking about a massive amount of life years that are impacted. Unfortunately, few survivors ever receive any survivorship-directed care, and they live their lives with suboptimal quality of life, many health issues, and early mortality, or they're at risk for early mortality because of the lack of survivorship care that they receive or don't receive. We've talked previously that chronic health conditions are frequently seen in survivors of AYA cancer. If you compare our survivors of AYA cancer compared to the general population, there's a much higher risk of developing health conditions, post-cancer treatment, radiation therapy, surgery, chemotherapy, all place patients at risk for different chronic health conditions. There's also a higher risk of developing multiple chronic health conditions, and we know that there's a higher risk of death from these chronic health conditions compared to the general population. Minoritized populations have a higher risk of developing chronic health conditions compared to non-Hispanic white individuals. Our team has looked specifically at some minoritized populations of survivors of AYA cancer. This is just a glimpse into one study that we recently published. Amy Berkman led this study using the National Health Interview Study, which is a publicly available database, surveys 30,000 individuals in the US every year. And we identified survivors of AYA cancer, specifically wanted to look at the population who identified as lesbian, gay, and or bisexual, noting that that does not include all folks' identities, but that's what data we had access to. We looked at the development of chronic health conditions in individuals who identified as lesbian, gay, or bisexual who were AYA survivors, compared their outcomes to those who identified as lesbian, gay, or bisexual who were not AYA cancer survivors, and then compared to survivors of AYA cancer who identified as heterosexual. When we just looked at socioeconomic outcomes, so how did people do in life who identified as LGB, who were survivors of AYA cancer, those individuals were more likely to live above the federal poverty line, and they were more likely to have psychosocial and socioeconomic distress in their lives. When we look at chronic health outcomes, as you can see in the figure on the right, those survivors who identified as LGB were much more likely to have chronic health conditions compared to the other two control populations. We saw the same thing when we look at Black survivors of AYA cancer and Hispanic survivors of AYA cancer compared to their relevant controls. So we know that in addition to chronic health conditions, secondary and subsequent cancers are a big concern for patients and lead to a significant amount of mortality in the population. HPV-related cancers are preventable now. We have a wonderful vaccine that is very effective and very safe, yet many individuals in this country do not ever receive the vaccine. We know that survivors of AYA cancer, or specifically our survivors of childhood cancer and younger adolescent cancer, are at a higher risk for developing HPV-related cancers. And we also know that many of these individuals never receive one or the full series, one dose or the full series for the HPV vaccine. We also know very little about HPV vaccine immunity post-treatment. So those who were vaccinated prior to cancer treatment, what happens to their immunity post-treatment? This remains a gap in knowledge. We need to fill the gap and make sure that all of our patients are vaccinated and protected against HPV-related malignancies, which include cervical cancer as well as head and neck cancer. I realize I'm moving pretty quickly. I apologize for that. I just want to make sure that we utilize your time as efficiently as possible. All of these domains of health-related quality of life are relevant to AYAs in life, and then cancer often makes each of these more difficult. We've looked at a few areas of distress, specifically in relationship to health-related quality of life, and I want to highlight a few here in terms of gaps that we need to fill. When we look at psychosocial distress, globally, John Salzman and others have clearly noted that there's a higher level of psychosocial distress on and off treatment for survivors of AYA cancer. If we narrow in and look specifically in Hispanic survivors of AYA cancer, there's high levels of distress with about 40% of individuals identifying moderate to severe levels of mental distress. And what's most concerning on this slide is when you look at those who have acknowledged a mental health care visit in the past year, it's only about 16%. So there's a gap of about 25% who clearly have a need for mental health care and for some reason are not receiving that health care. And we see here that about 10% of individuals say that they're not able to afford mental health care, so access continues to be an issue for this population. Relevant to not being able to afford care, medical financial hardship, financial toxicity, whatever term resonates the most with you, this remains a huge challenge. This is a really nice study led by Susan Parsons and colleagues just a couple of years ago showing the true economic cost and toll on patients in regards to being diagnosed with cancer as an AYA. And she noted that it was about $260,000 of loss per person over the span of their lifetime, with most of those costs being due to lost productivity, loss of well-being, and loss of life. There is a number of domains that are impacted by medical financial hardship. You can see those in the figure on the right here. We know more and more that being diagnosed with an AYA is crushing to individuals for their education, for their vocation, and for their ability to support themselves and their families in the future. We've talked about chronic health conditions. We've talked about mental health conditions. We've talked about financial hardship, and now we get to survival. When we look at long-term overall survival, there is a big gap that we need to fill, and that's the gap on the left between the red and blue bars there. So here we look at 5-year survival of AYA for AYA cancer patients. And what we see compared to the predicted survival for the US population in red, our survivors have a steep drop initially between 5 years and 10 years post-diagnosis. That's mostly due to relapse and progression of their primary disease, but the slope continues to be suboptimal as you move further and further away from diagnosis. And that is likely death due to late side effects of treatment. We do see significant improvement in earlier cure rates for those patients by decade. However, I'm concerned that the late effects that are present, while they may be changing and maybe there's a decrease in some radiation-related late effects due to decreased use of radiation, there's other late effects that are unfortunately still associated with long-term morbidity and long-term mortality. What do we do about this? It's not all doom and gloom. I didn't show you the fact that 85% of all individuals diagnosed with AYA cancer will be a 5-year survivor. So we're making progress. We need to make more progress specifically for our long-term survivors. So there are long-term follow-up guidelines for survivors of childhood and AYA cancer. And I will highlight in red here that the impact of these guidelines lie in their ability to be implemented and the widespread adoption of these guidelines. Currently, and this is my bold statement for this talk, I do not believe survivorship care exists for most AYAs treated for cancer. Most AYAs, they get treated, they go off into the world, and then they never get their survivorship needs addressed, be it physical health, psychosocial health, financial health, any sort of health and well-being that you could think about that can be impacted by cancer. Post-treatment survivorship care needs to focus on screening for and prevention of early onset chronic health conditions, subsequent malignancies, specifically focused on long-term health and wellness. And we need to increase access to care as well as provider knowledge and awareness and support these providers to provide the 2 million plus survivors of AYA cancer that exist. So how do we do this? This is a really nice framework by Melissa Boscheman, which was published a couple years ago. It also identifies a number of the gaps that we talked about today, and it gives you a little bit more in-depth information. Please consider clicking on the QR code. Actually, don't click, but put your phone up to it and open the QR code if you want some more details. But essentially what Melissa's highlighting here is that there's not a one-size-fits-all solution for any of the gaps that I mentioned. This is not like identifying a patient who has sepsis and identifying the bacteria causing sepsis and just saying this is the antibiotic we need. There are multiple levels that need to be addressed to improve outcomes for each of the gaps that we talked about today. And unless we understand and address each of these levels, patient, provider, institution, system level, we're not going to see meaningful improvements and lessening of these gaps. I do believe that we're making progress. I believe we're in the age of folks being inspired to serve this population. The National Cancer Institute has identified AYA care and outcomes as a priority. The Office of Cancer Survivorship at the NCI is very well versed in caring for this population, and that they know the needs for this population. I think we're in that time point where we're going to fill these gaps, but we need more progress and it needs to be faster. So in summary, what are our opportunities to further improve care and outcomes and fill these gaps? Access to care is huge. We saw with the ACA that if you increase access to care, outcomes improve. We need to make sure that patients receive high quality care no matter what cancer care setting they present to. And we need to standardize both treatment-based approaches as well as survivorship care across our pediatric, medical oncology, academic, and community sites. Access to clinical trials is imperative to further identify optimal approaches to improve survival and quality of life. And really, it's about collaboration. And that's why we're on this call today. It's collaboration between pediatric and medical oncology, all different stakeholders. It's collaboration with patient advocates. It's collaboration with primary care for survivorship. On that note, I'll say thank you to all of you for showing up. Please don't hesitate to reach out to me if there's anything I could assist with, and looking forward to addressing some of your questions. Thank you so much.
All right. Well, thank you, Mike. That was awesome, as usual. If anybody has questions, if they wanted to put them in the chat or in the Q&A section, but you're getting lots of clapping, so I'll add claps. But one comment that was already in the chat earlier is, when do you think is the optimal time to start talking about survivorship? That some of us want to talk about it from the beginning or ASAP, but often from what you're describing, it seems like it's meant more for post-treatment.
Yeah, that's a great question. So as someone who's a survivorship doc who also sees patients upfront and early for newly diagnosed disease, I think it's important to bring up survivorship care and late effects very early, but also not overwhelm patients with the details. I usually highlight that patients are at a higher risk for chronic health conditions. after treatment, and there's a need for lifelong survivorship care, and that can be delivered in different care settings. And then the intensity of those survivorship questions increase as patients get closer and closer to completing treatment. Oftentimes, transition to survivorship, if it happens at all, the earliest many patients would be transitioned maybe 2 years post initial diagnosis. More commonly in survivorship clinics, it's probably closer to 5 years post treatment. Unfortunately, for most patients, they just fall off, go back into the community setting without any survivorship recommendations, which to me really highlights the importance of developing care summaries and so treatment summaries and care plans, meaning patients need an echo every X number of years, colonoscopy starting at age 30 because they receive radiation to the abdomen. So really good question. Everyone does a little bit differently, but it needs to happen. And the patient needs to be informed as well as their providers in the community setting.
And then regarding the COG survivorship guidelines, people often hear about providers that they don't think that their AYA should be followed because it's too much of research is done on peds rather than AYA patients populations. What are your thoughts on that?
Yeah, I appreciate that comment. There's a huge gap for our AYAs. Unlike most things in oncology where treatment approaches and new drugs come down from medical oncology to pediatric oncology, survivorship's made its way up from childhood cancer survivors to now survivors of adult cancers. And in the AYA population, we probably know the least of any population as to their long-term outcomes. We do know a fair amount about the youngest AYAs, so those older adolescents who are incorporated in some of the pediatric studies. We're learning a lot more about survivors of AYA cancer, and as expected, we're seeing disparities in care and outcomes. I think guidelines and the COG guidelines are a good place to start for AYAs, and it's much better than what we're doing now, which is for most patients, we're not doing anything, and we're not increasing our screening for breast cancer, colorectal cancer, meningiomas for those diagnosed at AYAs, even though we're seeing higher rates of subsequent cancers in these populations, and there's been recent publications showing that as well.
And in terms of the survivorship care plans that you mentioned, and seeing the rise in the creation and delivery of them, what can we do to advocate for these to be more of a standard practice?
Yeah, that's a great question. So this is still controversial. A number of years ago, the Commission on Cancer, which is a big body that provides accreditation to many cancer programs across the country, they sort of mandated the development of treatment summaries and care plans for sites, and the sites couldn't meet that recommendation. And then there was a period of time where there wasn't a lot of evidence regarding the efficacy of care plans. I will give you my bias that I think the studies that are needed sort of haven't been out there yet. I think a simple care plan of just stating sort of what was the exposure and what needs to be done for that is effective for our patients, and our primary care providers who see these patients later on in life appreciate them, and it helps with actually getting the screening done. With that said, if it's not required, oftentimes sites won't do it. So I would strongly be in favor to, pushing sites and advocating for sites to just think of what's the lowest burden care plans you guys can develop with the resources you have, because patients are right now just going off into the world and not receiving the necessary care that could improve their outcomes and their health.
So along those lines of people kind of going out into the world, as you were just saying, any tips for AYAs who leave for college and are still either in treatment or they're in the monitoring phase?
Oh, great question. We don't want to hold our AYAs back. We want to help them meet their goals, whatever they might be, as long as it can be done in a safe way. Many patients can get care locally. The challenge is you need to be proactive and identify a provider who's willing to care for you. And I think we as providers need to connect with the local providers or provide them some information, provide our contact information should there be challenges. But we don't want to hold our patients back and contribute to the financial toxicity and poor health outcomes from a psychosocial health outcomes and goal achievement. I advocate for my patients, wherever they're going to move in the future, let's identify, is there a relevant survivorship program nearby? If not, let's identify a primary care provider who you feel comfortable with and they feel comfortable with you, and give them the tools to be able to care for you. Last thing I'll say is I don't think survivorship care in terms of the recommendations are that challenging, meaning I follow a recipe, right? They got radiation, they need breast imaging this often. They receive this dose of anthracyclines, they need an echo this frequently. The challenge is that people just don't know the recipe. So if you provide them the recipe for a primary care provider who cares for older adults who have CHF, who have diabetes, who have multiple chronic health conditions, they don't have any challenges ordering these tests and following these patients. They just don't know that a 30-year-old who walks into their office really has the health of a 60-year-old, and they need to think about them differently.
And have you ever, especially for the college students, have you ever worked with the student health at colleges, or do you usually try to find someone in the community?
Yeah, that's a great point, Scott. I usually recommend the College Health Center because it's easily accessible for patients. Any students have access, and there's really no barriers to engaging there. And if you think about these college health centers, they are seeing individuals who've been diagnosed with cancer, especially at the larger universities, because just thinking of the numbers, a certain proportion will have had a childhood cancer, will have had an AYA cancer, or will be going through cancer while actively attending college.
And again, continuing on these lines of monitoring, what are your thoughts in terms of how long the oncologist should continue to see someone? You mentioned earlier people get transitioned either 2 years or 5 years. But what's your personal thoughts on that?
Yeah, I think it really is guided by the resources available and just making sure that all patients have access to some survivorship care. So I'm a little bit spoiled. I work at a site where I'm able to see my patients decades after they complete treatment. However, we know that that isn't feasible for most sites. And we also know that as our AYAs age, our personal expertise may not be ideal for their long-term care. I am a pediatrician by training, right? I'm a pediatric oncologist. I did pediatrics. I do see patients in their 40s and 50s in my current practice in AYA survivorship and childhood cancer survivorship. That said, I stick to what I know. I make sure they get their screening tests. But when it comes to managing older adult issues, I still need them to have a primary care provider who I work with to ensure they get all of the other recommended care for those things that I was not trained to provide. So I think it depends on what care setting you're in. You just have to make sure wherever you are, your patients have access to some dedicated survivorship care. I personally think PCPs are the sort of the future for survivorship care for patients in general. I lead the survivorship program at MD Anderson for older adults as well. And there's just not enough resources to provide, survivorship care long-term for all of the individuals within the walls of our institutions. It's just not feasible. So those PCP partnerships are key.
Yeah. And I guess I would also add that it probably depends on what we're talking about in terms of those screening, right? Because even for the question about how long does the oncologist need to follow them, are we talking about monitoring in terms of relapse, or are we talking about their survivorship guidelines from long-term effects? And sometimes we lump all of that into one, but those different parts can be separated out, and depending on who or what you're screening for, different people can do. And then where'd this one go? In terms of screening for mental health, how do you go about checking on patients without overwhelming them or sort of quote unquote inflicting certain emotions in terms of screening?
Yeah, that's a great question. So I personally think that our AYAs want to be asked how they're doing, how their life is going, what are their challenges, if we have an opportunity to address those needs. So within our AYA clinic, we have a patient-reported outcome inventory. We use the Promise short form tools where there are a few questions in, anxiety, depression, neurocognitive health, fatigue, and we use that as a screener to identify who would benefit from additional resources. We have the luxury of having social work support within our clinic, as well as AYA counselors for those who need additional mental health support. That's taken time to build and to grow the program. But I don't think we can shy away from asking, knowing that 30 to 40% of all of our survivors will have mental health needs. It exists. If we don't ask, it still exists, and likely over time just compounds and gets worse.
And there was a question also about standardizing cancer treatment across centers. Do you believe screening programs could play a role in this, and what are the barriers to implementing screening?
Yeah, that's a really good and challenging question. I don't think we've figured that out at all yet. So we have a hard enough time retrospectively identifying what treatments patients have received based on cancer care setting. I think there's a lot of hesitation in terms of referring AYAs out of your site or institution to someone who's an AYA specialist. We have a lot of geographic disparities, challenges just in patients who live in rural communities where access to care in general is really difficult. And it would be hard to get them to a site that has a lot of experience with AYAs. I think we need to do a better job centrally of making ourselves and our AYA experts accessible to help guide our sites that don't see as many AYAs when they have questions that come up for how best to treat their AYA with sarcoma or ALL. But we are far away from addressing that gap, and it's a huge challenge that we really haven't come up with a good answer yet, other than developing NCCN guidelines and other guidelines and recommendations that are tailored for AYAs as an initial step.
And I guess maybe I can ask a follow-up to that. What kind of outreach is being done for the PCPs, right? You're saying for that the AYA and survivorship specialists should be available, but sometimes people might know who that person is to contact or what they do. So what kind of connection, collaboration, outreach can we do within the
Yeah,
community?
great question. There's a new push by the NCI's Office of Cancer Survivorship to focus on survivorship care in the community setting. So some of those resources will likely be coming soon. I can tell you at MD Anderson, we're developing an ECHO, so a training program for primary care providers to increase their knowledge and comfort caring for survivors. American Cancer Society has an AYA and childhood cancer survivor ECHO that is ongoing, that tries to reach out to primary care providers. I think the challenging part of this question is that while many PCPs, or almost every PCP, will see survivors of AYA cancer, it's still a minority of their population. So how do we get them the tools that they need, understanding that they see many more patients with heart disease, many more patients with other needs, and they can't necessarily drop everything and prioritize the needs of AYA survivors or spend weeks and weeks learning about the needs of these patients because they have 40 patients they're seeing each day. And this is, the 5 patients they'll see in a couple weeks or a month. I'm not trying to minimize the needs of this population. I just think we have to be feasible and think about what would be acceptable to increase their comfort and ability to care for these patients.
Yeah. And I love the comment about seeing adult survivors of pediatric cancer center with their oldest patient being 88 years old who was treated for Hodgkin lymphoma in 1956. So wow.
You,
But really the idea,
you beat me. Yeah, mine is 1969. So you've got me.
but I really love the idea about empowering the AYAs, which I think is super important. And as we were talking about some of the barriers earlier, but empowering them because a lot of them, yeah, they were too young to understand the potential risks or what needed to be done when they were younger or when they were teenagers. So really focusing on that education and patient information and family information for that empowerment.
Yeah.
And then someone's linked in the chat that GW has a series on this.
I agree. That's an excellent series, Betty. All right, I think the firing squad is done. I will just say thank you to all for just remaining engaged. We have a lot of work to do. Again, this wasn't meant to be all doom and gloom. There are so many gaps. We're making progress. I guess the title of this was Gaps in Care, so that's why it seemed a lot more negative than positive. We're in a much better place than we were a couple of decades ago. And we also need to keep filling these gaps to make more progress, because our patients still have many more needs. So thanks, Kayla and Nick, for providing the forum to share this, and hoping you guys will share this talk with many others, just to make sure that people are doing their part to care for these patients.
Absolutely. Yeah. Thank you so much, Mike. And I think what is so beautiful about this first session is how much it sets up kind of the next step of the conversation with the rest of the talks that we're going to be having with Power. So I think that's kind of the great kind of catalyst and kickoff for it, is that the remaining session and kind of schedule that we have left will continue to dive a little bit deeper into some of these themes and topics. So with that, I have two things just to very quickly drop in the chat. First and foremost, we really do rely on the feedback of this community to give us your input. We used a lot of that information to create the topics for season 2 based on kind of what we learned from the first season and what you all shared with us. And then the second thing that I am going to drop is the registration link for our next session. This is going to be taking place on Tuesday, November 5th. At 5 p.m. Eastern, so it's a little bit later. Hopefully we'll be able to connect with even more of you there. And Dr. Tara Henderson will be talking about AYA survivorship and kind of the long-term effects and challenges of caring for that community. So we are so excited for that. Please be sure to check out our website to learn even more, check out our previous sessions and all of our amazing on-demand content from wonderful experts in the field. Thank you to Mike and Scott for being here and being a part of the team. And we will see you all in November. So thanks, everyone.